So we'll keep moving on, guys. So we're going to talk about some really exciting stuff, some postoperative dysphagia, which I can guarantee you all of you will see this. If you do any ACDFs, you will see this. So here's the disclosure, none of these are relevant. So I thought I'd start with a case. So it's kind of pretty standard, 72-year-old guy, spondylotic myelopathy. He's had, I think I was following him for about a year, and over the past 6 months he started getting really bad. And we decided to move forward, kind of a classic 2-level ACDF, 4, 5, 5, 6. I usually do these on a Thursday. I did them on Thursday, uneventful. We sent them out that day, so it's the same day surgery. I went to a family wedding in California on Friday afternoon, but I usually call them, so I check in with them. I always call them, and Ricky told me this, I call them the night of, so I call them Thursday night, he did great. And then my NP will usually call him just to check in, make sure the meds are working, unless we have to tweak anything. Friday, he was doing great. I fly to California that afternoon, and then Saturday morning, like at 2 a.m., my phone's getting blown up by this ED doc. So here's a kind of post-op film, you see, kind of uneventful, no big issue. And this is what the ED doc is like calling me, and she's one of my friends, and she's like, hey, you got this patient in here, he's not doing good. I'm like, my wife's like, will you keep it down? I'm like, oh, shut up, honey. And I'm trying to look at my phone, like I'm trying to look at these images, I'm like, these are not good, I'm like, what's going on? And she's like, oh, and I'm kind of like, the phone's breaking, I'm like, just send me a video, like what's going on with this guy, just send me a video. So hopefully you guys kind of get a good sense of this.
What city do you live in?
Yeah.
Okay. And who's your doctor?
Dr. McCarthy.
Okay, thank you.
So for you guys like love social media and stuff, don't put that on your social media page. It's not going to attract patients, okay? So it's kind of like culture like Brian's, like Donald Duck thing. You get this, I'm talking about, you want to freak out, and you're like 2,000 miles away, like, oh my God. So I called my partners, we admitted the guy. Actually, they did not take him. They just hit him with some steroids, and he actually did fine afterwards, which was really surprising. I thought, I'm calling like, take him. Like, no, he's actually okay. So he did fine though. But let's talk about dysphagia. Let's talk about the things that can cause it. And so let's kind of get into the basics. So the basics of swallowing. So really these are 3 phases, kind of the oral preparatory phase, and that's just basic. It's food going in your mouth, mastication, chewing. And then it kind of gets a little bit more complicated in the pharyngeal phase, where you see kind of the larynx elevate, the epiglottis flip down to stop food from going in the trachea. And then the upper esophageal sphincter opens up and allows that bolus to go in the esophagus. And then that enters the 3rd phase, the esophageal phase, which leads to the peristalsis and kind of movement of the bolus into your stomach, right? So when you think about dysphagia, what is it, right? So it's any kind of abnormality in the neural controls or structural controls that lead to kind of swallowing abnormality processes. So, and that's just kind of the basic definition. But what really is that? The changes in the biomechanics can be anywhere between impaired epiglottic conversion, pharyngeal constriction issues and peristalsis issues, prolonged transit time issues, and also reduced hyoid displacement. So what does that look like? So for the patients coming in with these types of issues, they'll kind of talk to you about like reflexive cough issues when they're having food intake. I tell you the most common things patients tell me is that it's not terrible, but I have to chew my food a little bit longer. I got to take a sip of water. And more often than not, the first, that 2-week follow-up visit when you talk to your patients, some of them that when they're having this type of problem, that's probably the most common thing they'll say. That wet voice quality, that Donald Duck type of thing that we're talking about, that can be kind of common. And then obviously, this is much further down the road when you're talking about recurrent pneumonia and repetitive aspirations. We see that, I mean, if you guys are dealing with stroke victims, that's usually kind of what we're seeing with that. But by the time you're seeing this, the cat's out of the bag. This has been a problem for a time. So how do you kind of assess it? Start with basic stuff, right? So if you're in clinic, this is not an emergent situation. You want to kind of differentiate between what's just odonophagia, right? So just painful swallowing, which can be from a whole multitude of issues. But you really want to talk to your patient and distinguish what's causing the issue here. For those kind of immediate post-op patients, figure out what's causing this, right? Reversible causes of problems that are happening, kind of thinking about the PACU or like post-op day 1, right? X-rays are important. Do a normal workup. Figure out, is the graft dislodged? Is there a plate malfunction? Post-op edema, hematoma, that soft tissue profile that you can see on the lateral X-ray. And then kind of, obviously you're not seeing this immediate, but maybe in the short term, a retropharyngeal abscess or something going on that line. But probably the most important thing to remember is this is common. This is a paper out of the Rothman guys that say about 71% of patients had dysphagia at 2 weeks. So I used to always say, oh, dysphagia is kind of rare, you're not going to have it. Now I've just switched my tune, and I just say, yeah, you'll probably have it. It's rare, but that it's going to be a permanent issue. But for the first day or so, 48 hours, you're probably going to have trouble swallowing. And mostly, I'd rather catastrophize the situation and set the bar really, really low. So when they come out, I'm like, oh, I feel fine. I'm like eating a hearty cheeseburger, like no big deal. So that I will tell you, that's how I kind of counsel the patients. But assessing them, right? So the first things first is, basics, cranial nerve exam, kind of saliva management, changes in the voice. Those are things that you're probably seeing. I mean, that doesn't take a long time. But at this point, if they're coming into your office with dysphagia, you're getting ENT involved, and then you're going to start going down that path, whether it's a direct, indirect laryngoscopy, video swallow studies, and you're really starting to get some better understanding of what is the issue here. Scoring, probably the most common scoring mechanism you're going to read about is the BZAS, and this came out of that early 2000s paper. They had about 250 patients, and they looked at 1, 2, 6, and 12 months, and you can see that decreasing trend of dysphagia during that time course. But they identified some early things in this paper that showed us that increasing levels had higher rates of dysphagia, and they talk about the female gender, and we'll get into that a little bit later, but things that we kind of find out. But in reality, really kind of the validated scoring mechanisms are the E10 and the swallow-qual. So for you guys thinking about research and stuff, obviously you're going to probably lean on that, but the BZAS is obviously probably the most discussed as far as the literature goes. So who's at risk? Who's going to have a problem when you think about your planning your surgery? How do you talk to the patient pre-op? Is it at 3-level? Is that 4-level ACDF? Is it a guy who looks like this? Right? Is it a front back? Is it maybe a skip level, or is it a high cervical? Right? You really want to kind of be able to kind of identify what are the risk factors. So what leads to dysphagia? So we talked about gender. Females potentially have a higher rate. There's also some literature shows that there's really no gender predisposition. Age, older folks, can they have it? Smoking status, revision, surgery, ET tubes. Operative times. When I think about OR times and retractor times or EBLs, they all kind of run together, right? Because that really is problematic. If you're spending 2 hours on a 1-level ACDF, 2.5 hours on a 1-level ACDF, you got to start to speed it up a little bit more, right? That is a lot of time that you're hogging on the goose. Or I think Brian gave a talk yesterday talking about soft tissue releases, allowing you to really be able to move it over, so you're not pulling so hard on it. Number of surgical levels, right? This paper up here shows about a 4-fold increase when you have four levels or more. Use of plates and plate thickness. This is a kind of a classic study by Mike Lee showing that thicker plates had higher rates of dysphagia. Utilization of BNP, we talk about not only swelling but seromas in the anterior cervical spine. But we've also seen some trends change as far as BNP use. And obviously this is very much off-label, but this is a recent paper talking about low-dose BNP. And then kind of the subtle things like unrecognized GERD, that maybe you didn't pick up on that and it's flaring up during this post-operative that's leading to their dysphagia issues. So what are some of the strategies that I think you can really employ? So you think about medications, you think this esophageal traction has always been a long-standing topic of debate, and Adisu Mesfin presented this double-blinded randomized control trial at the last CSRS meeting. It was fantastic. It essentially shows it doesn't work. It doesn't really change whether it's pre or intraoperative manipulation of the trachea. Can that help maybe stretch out some of the soft tissues? And his data showed that really was no difference. Endotracheal kind of manipulation and cuff kind of afterwards, maybe let it have the anesthesiologist kind of maybe take down the cuff pressure after you get your retractors in. And then cervical plate design, I think kind of a smaller plate. I'm always kind of, that's always, anytime a company comes by, I'm like, how thick is your plate? Let me see your plate. ACDF versus arthroplasty. This is kind of, in my mind, I always think about an arthroplasty or even a standalone cage. I'm not using the plate. And then Rick kind of showed that maybe there's some data to show that there's less dysphagia in CDRs versus ACDFs in that kind of late term follow-up. And then steroids, right? And there's been tons and tons of studies, multi-level studies. This is one of Alpesh's studies showing the effects of steroids. And I think at this point, this is clearly shown to have some impact as far as reducing dysphagia. And whether it's local application or IV application, it has definitely shown to show less rates of dysphagia. There's a little bit of criticism, could it lead to higher rates of non-union or esophageal perforations? And it really, I think so far the literature has not really showed us that that's really that big of an issue. So what are the take-home points? Dealing with this is not rocket science, but getting ENT involved early on, I think, in your post-operative patients is important. My personal take on this, again, this is just my personal take. I'm not a big fan of table-mounted retractors because I think it's just a stable pressure, right? I'm constantly kind of taking pressure off the goose. So especially if I'm doing a 2-level, 3-level ACDF, between every level, I'm like, all right, everybody out of the pool. Everybody out of the pool is what I tell the fellows. Take the retractors out, right? Give the time to the goose to kind of come back over and chill out. I like IV intraoperative steroids. Again, the thinner the plate, the better in my mind. And as Brian talked about, what's the plate there, right? To help with what we know for a stability reason, right? To make sure that this thing can go on to fuse, right? And I think sizing your graft appropriately is really critical. So it's the subtle things that we do in ACDF that really allow us to maybe stretch the thinner the plate. Maybe I'm relying less on my plate, so I don't really care that it's a really thin plate or a small plate, right? I will tell you from personal experience, avoid 4-level ACDFs if possible. Just try not to do them. You'll see people do these crazy 4-level ACDFs. It is a pain in the butt. I've never enjoyed them, and there's always an issue, and they always have dysphagia. So avoid those if you can. I'm also really liberal with Medrol dose packs. If I'm doing a 3-level ACDF, they automatically get a Medrol dose pack unless it's contraindicated. And then as soon as they start calling me off saying I'm having some swelling issues, first thing my NP does is she gives them some steroids. So just, again, these are my kind of the recommendations as far as you guys starting out. So thanks. Any questions?
Mike, what about topical steroids?
So topical steroids, like a local steroid, obviously is grouped in a lot of those multi-center studies, and even Alpesh's study that I showed up there, and those are shown also to show decreasing rates of dysphagia. So I don't really like the idea of squirting steroid right on top of my plate. It always kind of weirds me out. So that's why I have a tendency to use more IV steroids.
Does it cause esophageal?
So I will tell you that there's a couple studies that have shown that maybe it causes esophageal perforations, and I think overwhelmingly that's showing it doesn't.
Yeah, the data does not support that at all. Like, we were more worried about non-unions, actually.
Yeah.
Right? So we've been tracking that RCT population, and we had 3 arms: IV steroids, local steroids, and control. And our non-union rate is exactly the same in all 3. But the study wasn't powered to detect non-union, right? So it's underpowered from that perspective. The way we got to using steroids was that our ENT surgeons, when they're doing revision work or redo surgeries, they'll actually put topical steroids on quite a bit to help with their post-op dysphagia. So I went back and I asked them all, what about esophageal perforation? And they looked at me like I was an idiot. That's just not a cause and effect. So I don't think that's a real thing, but I do think non-union is a thing that you need to be mindful of.
Yeah. Anybody else?
Can you talk about one dose or preference of steroid and IV? Like at what point do it?
So the anesthesiologist will almost always give it kind of right at the start of the case. I will, so it depends. So if the ASC, they might not get another dose, but if I'm keeping them a little bit longer. So for instance, if you live down the street, right, and then you're leaving at the 3-hour mark, I will not give you another IV dose before they leave. But if you're going to stay for 23 hours, I'll hit you with another 10 milligrams, second run. And then it's just a Medrol dose back afterward, as outpatient.